Assalamu alaikum. This is history and general examination of a child with respiratory disease. A large percentage of the time, you will actually be able to make a diagnosis based on the history alone. The value of the history will depend on your ability to elicit relevant information. Successful interviewing is dependent upon your already well-developed communication skills. At the beginning of taking the history, we should know the child's age, and the history must be adapted to the child's age. And also we need to be flexible and maintaining a sense of humor during history taking. Children are divided into many age groups: newborn, the first week; neonate, first month; infant, first year; toddler, 1 to 2, and some say 1 to 3 years; preschool, 2 or 3 to 5 years; school age; and adolescent. Opening the consultation with introduction of yourself and your role, and confirming the patient details about the name and the date of birth of the patient, and explain the need to take the history, and gain the consent to take the history, and ensure the patient is comfortable during taking. There are some principles in taking history. First, give the patient time to explain the problem or symptoms they have been experiencing. It's important to ask or use open questioning to elicit the patient presenting complaint. So what brought your child in today? This can sometimes be difficult when talking to children, and you may need to adopt an approach involving more direct questioning. So instead of saying, "Tell me about the pain," you may need to ask a series of questions requiring only yes or no answers. To describe the presenting complaint of the patient, ask about the onset, the duration, the severity, the course of the illness, precipitating factors, relieving factors, associated features, and the previous episodes of the same problem. Here are some key pediatric questions about the presenting complaint. About feeding, you should ask about the volume of intake and the frequency of feeding. About vomiting, frequency, volume, timing, being projectile, bilious, or bloody. About fever, confirmed using thermometer versus subjectively feeling hot. For wet nappies and urine output, number of wet nappies a day, decrease in dehydration. For stools, ask about consistency, or having steatorrhea and biliary obstruction, or red current gel stool and intussusception. For rash, any obvious trigger, distribution, or blanching. For behavior, ask about being irritable or less responsive. For cough, ask if it is productive or associated with increased work of breathing. For rhinorrhea, which is usually associated with upper respiratory tract infection, viral upper respiratory tract infection. If there is weight gain or loss, check the baby book if the parent has it with them. The sleeping pattern, if he is more sleepy than usual, and if there is unwell contact, often children become infected from unwell siblings. You can clarify the details of pain using Socrates. Mnemonic. Site, where exactly is the pain? Where is the pain worst? Onset, when did it start? Did it come on suddenly or gradually? Character, what does it feel like? Sharp stabbing, dull ache, or burning? Radiation, does the pain move anywhere else? Association, any other symptoms associated with the pain? Time course. Does the pain have a pattern? Worse in the evening, say. Exacerbating, relieving factors. Anything made it particularly worse or better? Severity on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain you have ever felt. In the systems review for respiratory system, we ask about cough, wheeze, shortness of breath, noisy breathing, sore throat, snoring, and chest tightness. For cardiovascular system, ask about cyanosis, exercise intolerance, feeding intolerance. For gastrointestinal system, ask about vomiting, diarrhea or constipation, and abdominal pain. For genitourinary system, ask about dysuria, frequency, wetting, toilet training, leg swelling, or puffiness. For neurological system, ask about seizures, headaches, abnormal movements. For musculoskeletal system, ask about disturbance of gait, limb pain, or swelling. Inquire about how active and lively the child is, about feeding and appetite, about sleeping problems. Make sure that you and the parent or the child mean the same thing when describing the problem. Ideas, concerns, and expectations often addressed to the parents. Ideas: what are the patient's or parents' thoughts regarding their symptoms? We should know. Concerns: explore any worries the patient or the parent may have regarding his symptoms. And expectations: gain an understanding of what the patient or the parent is hoping to achieve from the consultation. And summarize what the patient and the parent has told you about the presenting complaint. This allows you to check your understanding regarding everything the patient or the parent has told you. It also allows the patient or the parent to correct any inaccurate information and expand further on certain aspects. Once you have summarized, ask the patient or the parent if there is anything else that you have overlooked. Continue to periodically summarize as you move through the rest of the history. For past medical history, ask about the antenatal period, illness or complications during gestation. For birth, delivery complications, prematurity, or birth weight. For neonatal period, illness, admission to neonatal care unit. For a previous hospitalization, when and why. For a previous surgery and accidents and injuries, remain vigilant for signs of non-accidental injury. Drug history. Ask about regular medications like, say, inhalers for asthma or other used over-the-counter medications. Ask also for allergies, all known allergies, not only allergy to medications. For the developmental milestones, you should ask about gross motor, fine motor and vision, speech, language and hearing, social, emotional and behavioral. Some of these milestones can be memorized, like sitting unsupported, walking around furniture, walking unaided. And from the fine motors, follow a pace, reach for toys, grasp with palmar grip, pick up small objects. For speech, startle to loud noise, coos and bubbles, turn head to sounds, say mama, dada, etc. Understand commands, say words, talk sentences. And from social, emotional and behavioral milestones, smiles, feeds himself solid food, drinks from a cup, helps with tasks like dressing and toilet training. For immunization, a detailed history of the immunizations received by the baby should be taken, not only enough to say that he is immunized up to date. For the dietary history, we should ask about the type of food, whether it is formula, breast milk or solids, how many ounces of milk he received, the frequency of feeding reduced or increased during the illness, special dietary requirement like cow milk intolerance or celiac disease, and for family history, the family history of diseases should be noted, like celiac disease, say, and genetic conditions like cystic fibrosis, and family tree useful to draw out if considering genetic disease. Social history is very important aspect of the history. Ask about the living situation, the accommodation, the main carer, who lives with the child, second-hand smoke exposure, risk factors for otitis media and asthma, parent occupation, pets important when considering allergies like asthma triggers, schooling stage of learning, any issues, foreign travel may be important when considering certain diagnoses like tuberculosis. Always don't forget to thank your patient and summarize the history again for him to know if there is missing points or not. For general examination of a child with respiratory disease or any other disease, these points should be covered. First, approximate age and sex of the patient. Second, nutritional status. Third, consciousness. Fourth, ill or not. Then, his posture and the skin, lymphadenopathy, clubbing, edema, measurements, and vital signs. For approximate age and sex of the patient, in this example, you know the importance of knowing the exact age of the patient in diagnosing the problem. Each age group has certain type of respiratory problems. If you see a newborn with respiratory distress, if the newborn is premature, the diagnosis could be respiratory distress syndrome. If he is full term, the diagnosis may be transient tachypnea of a newborn. If he is post-mature, the diagnosis might be meconium aspiration. If respiratory distress during infancy, it might be due to bronchiolitis. If it is during toddler age group, it might be due to pneumonia. If it is in older age group, it might be due to asthma. And the age groups of the patient is either newborn in the first week, neonate, first month, infant, first year, toddler, 1 to 2 years to 3, preschool, 2 to 3 years to 5, school age, 6 years to 12, and then adolescent. The nutritional status of the patient might reflect his illness. So respiratory diseases with malnutrition might be seen in cystic fibrosis, bronchopulmonary dysplasia, bronchiectasis, bronchiolitis obliterans, and immune deficiency. See if the patient is ill or not. Ill looking could be due to malaise, and see if the patient is still having malaise after defervescence, since persistence of malaise and severe ill health after defervescence might mean real bacterial or serious bacterial infection. If the patient is severely dyspneic, might look ill. If he is dehydrated, if he is lethargic or disturbance of consciousness, if he is in pain, is irritable or agitated. Look for signs of dysmorphic features and see patient with CNS problem might have aspiration pneumonia. Patient with a cleft palate, also aspiration pneumonia. Patient with micrognathia might have difficulty in breathing. Patient with gastroesophageal reflux might be a case of CNS problem or other esophageal atresia or others. Patient with tracheoesophageal fistula might end with respiratory infection. Skin is the largest organ in the body. Examine the skin for pallor, for jaundice, for cyanosis, and for skin rash. As you know, Cyanosis is reduced arterial hemoglobin more than 3 grams per deciliter or reduced capillary hemoglobin more than 5 grams per deciliter. It is either central or peripheral. The central are due to arterial hypoxia or normal arterial oxygen and methemoglobinemia and superior vena cava obstruction. In peripheral cyanosis, vascular causes, vasomotor instability, hypothermia, venous obstruction, shock, hypoperfusion, and venous stasis. Hematological causes of peripheral cyanosis could be polycythemia. Examine for lymphadenopathy. Examine all regions: cervical, axillary, inguinal, epitrochlear lymphadenopathy. For the number of lymph nodes, the size of each lymph node, consistency, mated together or not, tender or not, sinus discharge present or not, respiratory disease with lymphadenopathy like adenovirus infection, tuberculosis, or malignancy. For digital clubbing, we should show the patient how to do the Shamrod sign to see the diamond hole in between the nail beds or in normal people, or the open angle from the nail beds in clubbed patient. And you know that the causes of digital clubbing either pulmonary shunting and inflammation, cardiovascular causes, non-cardiovascular causes, and familial. For edema, look for puffiness of face, leg edema, ascites, scrotal, and sacral edema. They are seen in kwashiorkor, nephrotic syndrome, heart failure, and angioneurotic edema. For anthropometric measurements, measure the weight, the height of the patient. They are affected in malnutrition, in syndromes, cystic fibrosis, celiac disease, others. And look for the head circumference and measure it. It is abnormal in children with CNS disorders due to inherited syndromes or acquired diseases usually associated with aspiration pneumonia and gastroesophageal reflux disease. Measure the vital signs, the respiratory rate, the pulse rate, temperature, blood pressure, and you may add oxygen saturation. Here are some normal range respiratory rate measures in breaths per minute, in neonate 30 to 60, in infants up to 40, 1 to 3 years up to 30, 4 to 10 years up to 25, and more than 10 years up to 20. And here are the heart rates of certain age groups: 0 to 2 up to 140, 2 to 6 years up to 120, and more than 6 years up to 110. And for temperature, here is a chart for body temperature, the normal body temperature, the oral, rectal, and axillary body temperatures, and the forehead body temperature, and the cutoff point of fever. And for blood pressure, we follow the 90 percentile measurement for age and sex of the patient, and there are certain charts for that, and this is an example of a chart for girls 2 to 17 years of age according to the height percentile. For oxygen saturation, it should be above 94%. Any reading between 91 and 94, you should monitor the patient. Any reading equal to 90 or below, you should do immediate measure to the patient. He is in a state of hypoxia. We should look around the patient if there is oxygen administered, if there are inhalers or nebulizers, if there are any medications or IV lines or monitors around the patient, should be noted. Thank you, good luck, and I hope we'll see you practicing these things on your patients. Thank you.